So you are very welcome to this basic obstetric ultrasound training. It's an hybrid program, hybrid in the sense that we have a chunk of it online and the hands-on practicum sessions would happen on site. That's not happening online because we would want to practicalize the theory that we have been learning within the course of the week. So this is just like an introduction. The main lecture for week 1 will happen on Sunday, which is next week's Sunday. So this is just to introduce us to what each week entails, what will be expected to cover, how the program runs. Then if we have questions, we will be able to take the questions. So week 1 is like a basic introduction to obstetric ultrasound. There's a physics behind ultrasound. So understanding how ultrasound works, you already know is a sound wave. Ultra, it's microscopic, if I can use it, a similarity of the one we can see with visual, but is ultra, you cannot hear it, but it's still able to pass messages and pass messages that translates to images, so to say. And then you want to understand how these interact with tissues. Then in this module 1, would also discuss the instrumentation, the components of the ultrasound scan, the probe, the buttons, and the lights. So how you would literally be mastering how you will control the ultrasound machine. Now, no two ultrasound machines are the same, but the buttons will serve the same function. It's like I'm saying no two computers, no two laptops or desktops are the same, but if you have a letter G, it should be the same function of letter G across board. Then we'll also discuss transducers and scanning techniques. So we'll explore these different transducers. Those are different probes. If you are at HES, you will know we have like at least 4 probes. So we'll explore those probes and what they do. This is almost like a basic introduction to obstetrics generally. For the obstetric ultrasound, we're usually interested in the convex probe. Then we would also discuss the ALARA principle. ALARA just means as low as reasonably possible for your ultrasound scanning. There was a time when science would say that ultrasound is safe, but now a number of people are purporting that you cannot really guarantee that ultrasound is safe because it's also still exposing the baby to some levels of heat. And it's even said that in first trimester, some babies don't have the ability to regulate their temperature. So if you go on and on and on, because of lack of dexterity, because of lack of skill, an ultrasound scanning procedure that should take you at most 10 minutes, you are still there for the next 1 hour. You're not using a reasonably low dose. So we'll discuss ultrasound safety under that. That's just like the foundational principles that we would cover in week 1. So with week 1, we would expect you by the end of week 1 to be able to explain the principles of ultrasound physics, be able to identify and describe parts of the ultrasound machine, be able to optimize images using appropriate machine settings, be able to select the correct transducer for obstetric scanning, and then be able to apply safety guidelines during your ultrasound examinations. So week 2 now is like an anatomy of the pelvic structure, a woman's pelvic anatomy. You need to know what the normal looks like so that by the time you're seeing a pregnant uterus, you know this has deviated from the, it's still a normal anyway, but now it's in another physiologic state. So we understand the basic anatomy of the female pelvis. Then what does a female pelvic, the female's pelvic organ, what does it look like on ultrasound? So we'll discuss the sonographic appearance of the pelvic organ. Then scanning planes and probe orientation, we'll discuss that. Then we'll also discuss systematic pelvic ultrasound examination from the bladder that is being filled as an acoustic medium, like an acoustic medium. Acoustic is sound, so like a sound medium that will allow the echoes of your ultrasound to pass through such that you can see the uterus well, to the outline of the uterus, to the adnexa, which are the ovaries, then to the pouch of Douglas. So step by step, how do we go about in taking an ultrasound examination for a female pelvis? Then of course we discuss documentation and image optimization. That's week 2. So week 3 now is early pregnancy ultrasound. Here, the plan and the intention is to recruit patients, even from the beginning of the program, to recruit a number of patients that would be used for demo. They're having the scan done free of charge. In exchange, they will be used for demo. So we would have very early pregnancy. Early pregnancy is between the time of conception to the 13th week. So the intention then is you want to learn how to confirm intrauterine pregnancy, so that even if the person has not done a pregnancy test with blood, how do you do a scan and you say, madam, you're pregnant categorically, and you know you're sure of what it is you're talking about. So you want to learn how to identify an early intrauterine pregnancy and distinguish it from other findings. Because when you look at the scan, there are so many things that look alike, but by the virtue of being schooled in it, you'll be able to say, no, what I saw is a gestational sac. It is not an abnormality. So you would want to be able to identify a gestational sac. The location, is it located within the uterus or outside the uterus? At which point we'll be talking about complications in early pregnancy, like ectopic pregnancy. You also want to be able to identify the yolk sac. Then the embryonic pole, that's the fetal pole. Because sometimes you can do the scan and all you see is the gestational sac. That's just like the sac that is supposed to house the baby. You've not seen the fetal pole. And then many times we'll say, come back in a couple of weeks when we are sure we'll be able to see the fetal pole. Once we've seen the fetal pole, we know, yes, we are dealing with a viable pregnancy. If you've not seen the fetal pole, you can't say you have a viable pregnancy yet, because there are, as you will see again, other pregnancy complications that will give you just a blighted ovum. You just have a pregnancy sac. You don't have a baby inside. Then still in the early pregnancy ultrasound, we would also be able to detect and evaluate the fetal cardiac activity using ultrasound. Then you would also be able to assess the pregnancy viability. At 7 weeks, you should be able to find the cardiac activity. If you've not got cardiac activity at 7th week, you begin to wonder, do I have a viable baby or do I not have a viable baby in this situation, as the case may be. So by the end of the 3rd week, you should be able to confirm an intrauterine pregnancy on ultrasound, even if the person has not done a blood test. You should be able to identify the gestational sac and the yolk sac. You should be able to identify the embryonic pole. You should be able to detect fetal cardiac activity. It's just to look at and cite it. You should be able to assess early pregnancy viability using ultrasound criteria. You should be able to document your findings accurately. You know, documentation is the gold. You would not do a scan and tell the person verbally, this is what we did. No, you should be able to write it intelligently and intellectually, such that a colleague that has that report is able to make sense and make meaning out of what it is you've written. Then week 4 is the first trimester dating scan. So there, many times you are measuring the crown rump length. Crown is the crown rump length. You can see the image here. It's like you're measuring from the head to the bum. A baby in the very early phase, around the first 8 weeks, looks like the similitude of a tadpole. That's the closest I can describe it. So when we say we're measuring a crown rump length, we're just measuring from the crown, that's the head, to the bum. So you want to learn how to measure it, because that measurement directly corresponds to the weeks of the pregnancy. But if you don't measure it wrongly, you would give an erroneous gestational age for that baby. So that would then bring you to learning how to estimate gestational age. If you can estimate gestational age correctly, you can estimate the date of delivery correctly. Then the dating scan protocols, you want to follow that step-by-step approach. Then, of course, documentation and reporting. At the end, you should be able to sit down and make documentation and reporting of what it is that you did in week 4. Now, at the end of week 4, we would have the exam for that month. The exam for that month would happen every 1st week, the next week. You know, if we finish week 4 by the 30th or the 4th week of a particular month, the very 1st week, when we are done with hands-on practicum for the next module, we'll just sit quickly, take the written and the exam. It's on site at the hospital here. So that's the way the exam will go. Now, I would pause to take questions in case you have 1 or 2 questions before I continue. Do you have questions, Kelvin?
No, ma. No, ma.
Okay. Now, Felix is supposed to be here. Well, maybe they will catch up with the video anyway. And I think there's one pharmacist that is supposed to be here. They will catch up with the video. Okay, so week 5, we are discussing early pregnancy complications. What are the things that could happen? Because it's not just to be able to scan a normal pregnancy. You should also be able to identify abnormalities, threaten miscarriage, missed miscarriage, incomplete and complete miscarriage. Now, the desire and the hope is that we would have patients who have these complications within the 12 weeks of the program, because it's just a 1-day practicum. But I will say if you are around, be on alert, because once I see such cases, I will just send you a quick message. Okay, we have this one, and please, can you come around and come and see it, so that it will be an opportunity to reinforce. But be that as it may, even if we don't have hands-on for these pregnancy complications, which is my own honest fear, all the other ones, I'm sure we'll get patients. All of them already have videos that we have uploaded the links. So it's to sit down and watch those videos. And then hopefully that when you get the hands-on, at least you should not miss incomplete miscarriage. And then I think I said it earlier that we would also now recruit patients for the practicum on every Sunday when people come. Anembryonic pregnancy is blighted ovum. It just means there's a gestational sac without a fetus. There's no fetal pool. There's no embryonic pool. Again, that you also would be able to identify that. Then ectopic pregnancy, that's pregnancy that is not sitting within the uterus. Be able to identify that. Molar pregnancy, though very rare, because honestly, I've seen only 2 cases. So we may not be able to have a live practicum for that, but at least you understand the theory behind it. Be able to watch videos of those who have done it, the scan, and recorded it, and then we'll be able to ask questions around that. Then subchorionic hemorrhage, that's bleeding in early pregnancy that is not from miscarriage. We'll also talk about that. And then there's this unusual term of pregnancy of unknown location. It is still at the end of the day ectopic pregnancy. But by the time we say someone has ectopic pregnancy, I have found the ectopic. I know it's in the right tube, or is in the left tube, or is in the ovary, or is in the pelvic cavity. I have found the location. But if the patient is obviously pregnant from the pregnancy test, HSG, beta HSG number is significantly high. The patient has missed menses, maybe like 3 months. So we're looking, 3 months is long. Maybe we say like 6 weeks. So we're looking for a 6 weeks baby. If it's a 4-week pregnancy, you may still say it's early. Let's do transvaginal ultrasound to be able to find it. But in this situation, this is 6 weeks that you should be able to cite it, and you still don't find it. And many times we'll give a diagnosis of pregnancy of unknown location. So you want to be able to apply systematic approach to identify and evaluate such. So coming to week 6 now, we're already in 2nd trimester. So essentially it's fetal biometry. That's measurement of body parts. Biparietal diameter is measurement of the fetal head between the parietal bone. And so there is a line of cut. It's not just that you find the baby head and measure. There's a line of cut that we call the FALX, FALX. So you find the FALX, but it means you're adjusting your probe. Okay, I've got the baby's FALX. Freeze the image. Now you take your biparietal diameter. Those are the things we'll cover in hands-on. Then head circumference in situations where you want to do that. Abdominal circumference, we would also discuss that. Femur length, we would also discuss that. Then how you will now estimate your baby's weight, the fetal weight. Oftentimes, if you have your biparietal diameter, you have your abdominal circumference, you have your femur length, even if you don't have the head circumference, all machines will automatically give you an estimated fetal weight and an estimated gestational age and an estimated expected date of delivery. So, but ability to do correct measurements by taking your image at the appropriate plane is a non-negotiable if you'll be able to do a reliable scan for your patient. And then, of course, you may want to also now incorporate your documentation and then report your biometric findings. So by the end of the 6th week, you should be able to obtain accurate fetal biometric diameters. You should be able to calculate the fetus's gestational age using the biometry. Those are the measurements you have taken. You should be able to estimate the fetal weight also with those measurements. Then be able to assess the baby is growing and compare with norm. What does that mean? from the woman's last menstrual period. I calculated the EGA and she should be like 30 weeks. Then I do an obstetric ultrasound and the fetal biometry is giving me 22 weeks. You know that baby is not growing. So is it that she's not sure of her last menstrual period, so she has a wrong date, or the baby is sick? Is one of the two. So, but you know, this index of suspicion has to be there for you to be able to make that recommendation that this baby, the growth or the dimensions are not compliant, not commensurate with the gestational age. So you would also want to be able to identify growth abnormalities, because such babies or fetus rather, you then place the woman on serial ultrasound and then you do comparative. If you're doing comparative and the baby is growing as it should, likely is the date that is not correct. If it's a fetus that is sick, likely you'll find that there's continuous decline in those your biometrical measurements that lets you know this fetus is ill, may have a condition very commonly, intrauterine growth restriction. So in week 7, here we're talking about lie. Lie is the position of the baby in relation to the mother. So if a mother is standing or lying down, supine, how is the baby? Is the baby in the same orientation? Is it parallel to the mother or transverse? If it's parallel, many times I would say it's longitudinal. If it's crossed, like a cross sign, you will say is transverse. It could be oblique, it could be a number of other things. So you want to be able to identify fetal lie because this is important for delivery. Then fetal presentation, what is the presenting part in the woman's symphysis region, in the woman's pelvic region? What's the presenting part? Is it head? Is it buttocks? Is it shoulder? So many times we'll say the baby is cephalic or is breech or has a shoulder presentation. Then what's the fetal position and attitude? Many times is assessed in relation to the mother's back. You would also cover that. Then the fetal cardiac activity would be covered here. So there's the difference between the cardiac activity and the fetal heart rate. A baby's heart is beating, is that the baby has cardiac activity. The heart rate is 180. That is tachycardia. That's fetal tachycardia. You know that's an abnormality. We had a patient that had a temperature of 40 and had fetal heart rate of 200. That is quite high. But eventually, by the time she will be investigated, we discovered that it was because she had a fever. She had a fever, had her own pulse rate was 155. Understandably, the fetal heart rate would also jump up. But your ability to assess that with the ultrasound scanning is also an important thing. Then fetal movement assessment. Sometimes we are interested in that. If a woman says, my baby has not been moving, it's just that kind of scan takes time and it may not be something I would ask you to do if you begin to work. It may be something that a senior colleague may want to sit on, but at least on a basic level, you should know what fetal movement assessment looks like. Then be able to also track basic fetal well-being. So at the end of week 7, you should be able to determine lie accurately. You should be able to identify fetal presentation and engagement. You should be able to assess fetal position and attitude. You should be able to confirm fetal cardiac activity. Is it there? Is it not there? You should be able to measure and interpret fetal heart rate. If someone has a fetal heart rate of 100 now, you should know grossly that one is abnormal. Then fetal movement, you should be able to assess that. You should be able to assess for basic fetal well-being and of course be able to document what it is that you have done. So in placenta assessment, you want to learn how to evaluate placenta location, structure, and identify abnormalities that can impact the pregnancy care. So the first is that we even need to understand anatomy of the placenta. So understand the structure, the layers, the blood supply. Then location, placenta could be anterior. Anterior means is in front of the baby. Posterior means is behind the baby. Fundal means is on the superior part of the uterus. We'll say symphysiofundal height, the upper part of the uterus. It could be lateral and a number of other things. It could even be placenta previa. That's a low-lying placenta. Here we will cover how you'll be able to determine that. Hopefully that we have a patient who has placenta previa that week, or we would be able to use the recording to reinforce it. But the way it will go is, since we are booking patients for hands-on practicum. We will not just sit with only what we plan to cover in that week. We will cover everything that can be possibly covered. So it means that you also have to have an open mind, because we can plan that 8th week we're going to do placenta assessment, and then it was on the 2nd week that we had a patient who had placenta previa. So you have to learn it and be very, very fluid in your learning, and just not be rigid and fixated on this is the bit I have to know for this week, because it's quite dynamic. Then we also learn placenta grading, abnormalities in placenta. What are the things that could happen? Placenta leaks, calcification, succinturate lobe, then umbilical cord insertion. That will be covered in week 8. So at the end of the week 8, you should be able to describe anatomy of placenta. You should be able to determine placenta location. You should be able to identify placenta previa, assess its type. You should be able to grade placenta using Granum criteria. You should be able to identify common placenta abnormalities. You should be able to assess umbilical cord insertion. You should be able to interpret findings and again document them correctly and appropriately. So now, any questions so far?
No, ma.
All right. So week 9 is amniotic fluid assessment. Two of the most common and more very challenging pregnancy-related complication is oligohydramnios and polyhydramnios. Oligo is the liquor is reduced. Poly is the liquor is plenty. Either of these are pregnancy-related complications that can negatively affect the way the baby comes out or the way the pregnancy goes. So, but here we understand the physiology and functions of the amniotic fluid. What does it do? How is it produced? What is the composition? What are the functions? What are the importance of the amniotic fluid? Then AFI is amniotic fluid index. You want to learn how to measure it. The machine we have can do that beautifully well. Every practicum session, we will do AFI. So you will be able to, by the time we get to week 9, you should be able to do that one like pure water. Then you understand single Depex pockets when we're measuring amniotic fluid index. So understand how to identify reduced amniotic fluid. What are the possible causes? What's the diagnostic criteria? And what is the problem that will happen? So that when you do a scan and you find that this pregnancy has oligohydramnios, it's not just to wave it off and say maybe when she comes in a month's time, it will have changed. It will not change. That's a disorder there that needs to be investigated, and of course, treatment began. We had a patient that booked with us, I think last year, upper year, and I just did one scan. The liquor volume was massive. It will interest you to know that what she just had was gestational diabetes mellitus. So it was seeing that prompted me to say, let's do your glucose. And by the time we did the glucose, it was up the roof. She was on insulin throughout that pregnancy. And I think by the second visit, our visit then was now every 2 weeks. By the second visit, which was a month later, the liquor volume had gone down to normal. But if the index of suspicion was not hit there, investigation was not done, we could very well have lost that baby prematurely, because the problem with polyhydramnios is that it increases uterine size. And the uterus will get to a certain size. Most uterus, by the time it has crossed 42, 42, 44 weeks, even if the woman is not ready to birth that baby, labor will set in, because the uterus can only stretch so much. So if polyhydramnios is stretching the uterus abnormally and the baby is not that mature, it was just liquor that was taking up space. You could have someone falling into labor at 32 weeks because the body senses that we are 40 weeks because liquor is taking up space. So it's something that you want to be able to recognize, understand the possible causes. How do we make a diagnosis, and then possible and potential complications around such. Then on an overall is that you want to be able to interpret amniotic fluid assessment with ease, so that by the end of week 9, what are the expectations? Be able to explain the physiology and function of amniotic fluid, be able to measure amniotic fluid index accurately, be able to measure single Depex pockets, be able to identify oligohydramnios and polyhydramnios, be able to interpret findings within clinical context, and then be able to provide appropriate recommendations for your patients. And then, of course, reporting and documentation are also important. So by week 10, we'll be learning about third trimester growth scan. So, well, you already learned how to do fetal biometry. That's how to take measurement. Growth scan now is you're tracking. Okay, so this baby is 32 weeks, and there is a growth graph that is expected for a 32-week baby in Africa. The growth graph varies based on culture and races. Caucasians have the biggest graph, if I can say, because you could have people who are birthing 5 kg baby naturally. 5 kg baby is very, very unusual here. Asians would usually have a smaller growth graph because their body is smaller. Eskimos of Alaska, I think those are the shortest population because they have to be small so that they can conserve it. They have a much lower growth graph. So growth graph is usually interpreted based on race and location. But the interest is that if I have a 32-week-old baby and I'm having a number of measurements, or maybe we say 39-week baby fetus, that we know this fetus is due for birthing, and then I have a weight of 1.4 kg. I don't even need a growth graph to let me know that that baby is sick. If I have a weight of 2 kg and I look at the mother and the woman herself is very short, maybe she's measuring like 1.4. Okay, I'll say genetically. So if beyond race now, genetically that may be responsible for why this fetus is measuring 2 kg. So being able to assess fetal growth is something we'll cover in week 10. Then being able to estimate fetal weight. This is just like reinforcing what we learned about fetal biometry. If you can do fetal biometry, you should be able to estimate fetal weight easily. Then growth charts and centiles. These ones, you don't need to cram it. Go online. My baby is 32. My fetus is 32 weeks. Oya growth chart for the African populace and plot the graph. Where does the baby stay? Is the baby in the 97th percentile or is in the 10th percentile, as the case may be? Okay, so it's not that if you have to track such growth, it's easier than maybe someone who has had the last delivery was 4 kg and it was a very challenging one. You know, that pregnancy, we have to track this next fetus because we don't want this next fetus to also now cross 4 kg. If the fetus now crosses 4.2, is irresponsible to recommend vaginal delivery. Likely you'll be able to say go for a CS, but that was because somebody was tracking the growth in that 3rd trimester. Then if fetal growth restriction also happens, you'll be able to identify that. So we'll be learning the definition, the types, and then sonographic indications. Then macrosomia are babies that are greater than 4 kg here in Nigeria. Outside the country, in climates where they usually will have bigger babies, some of them will have a reading of 4.5 kg before they call a baby macrosomic. But if you have a baby who is more than 4 kg, we'll say it's macrosomic. So supposing you do a scan at 39 weeks and the baby estimated fetal weight is 4.2 kg, you have to state it explicitly on that report that fetal macrosomia, so that it alerts the medical doctor or the managing nurse or the midwife that I have a macrosomic baby and it is unwise for me to allow this baby or this woman to go into labor. But you know, those understandings have to be there for you to be able to tailor all of this together. Then of course, documentation and reporting are also things that you would also cover. So multiple pregnancy assessment is also another thing, types of multiple pregnancy. We'll talk about chorionicity and amnionicity. The sac is the amnion. The chorion is the placenta. So you would have babies that are dichorionic, diamniotic. It means each individual have their own pregnancy sac and their own placentation. They are 2 different persons, fraternal twins, as fraternal as they can be. It could be monochorionic, diamniotic. So they have 2 different sacs, but they have a single placenta. Then it could be monochorionic, monoamniotic. So it is the same sac, both of them are inside. In fact, this is identical twins. This is one of the most risky twins because you will now come to learn about twin-twin transfusion syndrome. But now all of this could happen and you don't know how to delineate this. So the module here would cover your ability to delineate this. So you will not just be reporting that it's a set of twins. What kind of twin is it? Because if it's a twin that has monochorionic, meaning they have a single placenta, if you don't state it, the first twin could come out and an uninformed midwife decides to pull out the placenta before the next twin comes out. You already know what that is. That's placenta abruptio. It will compromise the life of the other twin. So that will be covered under multiple gestation, then twin labeling, as well as how you measure twins, because you could have a twin that is bigger than the other. Complication of twin pregnancy is twin-twin transfusion syndrome. It's many times fatal for the twin who is the donor. So there is the one who is the recipient that will be getting fat at the detriment of the other person. Then, of course, growth discordance. Maybe you do your fetal biometry for the twin. Now, the first twin is measuring 2.4 kg. The second twin is measuring 1.2 kg. You already know alarm bell should be going off. Something is off. These are things we would also cover in this module, because that is a kind of growth discordance right there. So week 12 is reporting, documentation, quality assurance. At this point, we are doing the final competency assessment. So would learn structured reporting, almost like reinforcing what it is we have been learning since. Then documentation and image archiving, quality assurances, ethics, all of those good things that wraps up a very well-structured program. So for this program, there will be a logbook that you will track procedures that you've done. And what I would recommend is even beyond the structured hands-on practicum that happens once a week, please steward your own learning on your own time. If you are at the hospital, you know that scanning happens every day, every moment. So you have to have that personal drive to say, can I give it a trial? You do it. If it's that you assisted, record assisted. If it's that you performed, record and performed. But that personal stewardship has to really be on point. I think this covers essentially this introduction grossly to each of the modules for the week. You're welcome, everybody. We had started before some people joined, but I see we are 4 now, and we are still waiting for the other people. I don't know how much of this you got, but I will be grateful if you can unmute so you can ask questions before we go to the second part. Questions, clarifications, comments, as the case may be. Please say something so I'm also sure that you can hear me. If you're quiet, I would assume I'm not being heard.
All right, ma. Thank you very much for everything, ma. So I think from my own side, everything you presented was I caught it from my own end here, and I believe when we will be starting, at least by then we'll have much to ask, ma.
Okay. All right, thank you. So the other part now is just to run you through how the program would run. We already know that we're meeting once a week. So the once a week would include lectures, more like let's reinforce what it is we've learned, the things you've watched on your own during the week. If you have questions, we ask about it, we ask the questions, then we now go to the scanning room and be able to do the hands-on practicum with patients that we have booked and selected for the free scanning and the practicum. So now there are 2 Sundays that we would not have the practicum on Sundays. We would have it on other days. The last Sunday of every month, I would drop like a schedule on the WhatsApp when I am done. The last Sunday of every month is pre-booked for me. Since I am the instructor, it's pre-booked for me, so I am not available. So the last Sunday of every month, instead of us having it then, we would have it the Thursday before then. Our lectures will be 3 to 5 p.m. We'll have the lectures, we'll have the hands-on practicum. I understand one of us is at, I don't know, maybe at Ado, but I know it's not in Oye. So we would also want to be mindful so that the individual will be able to travel back. So we don't want to start late at night. So we start by 3 p.m. We finish 5:30, 6 thereabouts. So for the last weekend, it will not be a Sunday, it will be a Thursday. Then the first Sunday for those who are HES staff, usually would have the monthly staff meeting. So it will not be the Saturday, the Sunday, it will be the Saturday before then. I will draft so that we just know for the next 12 weeks on what days are we meeting. Whenever it is between the hours of 3 to 5 p.m. We will try and make it such that we finish on the dot of 5 so that people can plan and we can also respect people's schedule. So that's the first thing I want us to keep in mind. The second thing is that we would have assessment every month. So the assessment happens after the very first Saturday of the next month, which is when we would meet. When we are done with the hands-on practicum, done with the lecture and everything, we would now sit and have our written assessments. The assessment will cover the module that we've done that week. That could be maybe week 1 to 4 for August. That will be done on the first Saturday of September. Then week 5 to 8, that will be done in September, will be done on the first Saturday of October. It's hands-on. You would also have slides of real ultrasound images and short clips that would then have follow-up questions for you to review and then attend to. So that would be done. Then when I explain the online platform for you, you would have reflections that is scheduled into every week. You're supposed to answer the reflection questions and mail the response to the email account that is provided there. So I think that covers what I need you to know about the way the program is structured. But as to the dates of our weekly meeting, I would curate that like a calendar and put it on the WhatsApp platform. Then the final thing is that on Tuesdays and on Thursdays, I will post case scenarios. Could be ultrasound images, could be short clips, could be a link, whatever it is. It's just meant to keep the interaction going, keep the learning going. You're supposed to look at it and respond. Now, I know this age and time offers us a blessing of AI, but I will kindly request, see if you can sit with it and attempt to answer it yourself. Don't just push the picture to AI and AI gives you an answer and then you post it. That way you would not really get much. Being a clinical program, you just need to know it. And ultrasound is like a game of pictures. The more you have seen, the more you know. So if you've seen a lot of placenta previa pictures, the day you see it live on scan, even if you've not seen it before, you know, no, I've seen this thing too many times to not know this is placenta previa. So those case scenarios, you want to engage with them. While it is not we would not be scoring it, but it's an opportunity to really steward your own learning positively. So that's for that. So I will then go ahead to share the link for the online platform. Then I will try and show you how to navigate it so that if we have questions, we'll be able to attend to that. Excuse me, please. So I shared the link here as a message on WhatsApp, and I'm also sharing the link on the WhatsApp platform. Please, wherever you are, try and see if you can log in. So coupon code is HES but I want to do a demo so that we will be able to, please, do you have the link? I would appreciate a feedback. Do you have the link, please?
Yes, ma.
All right, thank you. So I want to do a demo of if I have to sign in, if I have to register, how do I go about it? So I'm putting the link onto my browser like so. And when you put it in, you have two courses here. We have the basic obstetric ultrasound training, and then we have certificate in healthcare assistance. But what we are offering is the basic obstetric ultrasound. So you click on it like so. It says buy the course. But you don't need to buy. You click on checkout. It's not clicking on checkout on my own hand, okay? Okay, so now I clicked on checkout. It has brought me here, but it's asking a question. It says, do I have a coupon code? For which I have a coupon code. So I'm clicking here. Remember, I sent a message. I said the coupon code is HES. So I've written HES, and now I'm applying. And it says coupon code has been applied. Now, if you are not registered on Seller, it will say register, no biggie. Put your name on it, put your email, put your phone number. Why the email is necessary is that the link to access the course subsequently will be sent to your email account. But because I already have my own contacts registered, it would then say complete the order. I go ahead to complete the order. And now it says, thank you for your purchase. So I'm coming to access the course now. Now, if you look at the course, it says, currently I'm at 0%. I have not done anything in this course. And then you can see unit 1. Unit 1 is opened. Unit 2 is not open because it is dripped such that you have to be done with unit 1 to be able to access unit 2. So I start with resource 1 now. It offers me a link. For some of them, it's more than a link. For some, you could have 2 links, you could have 3 links in one resource. So, but I would open this, watch it, of course, read all of the instructions and the write-ups that are there. Then there's a note for week 1 that will open on another page. And then you go through the notes. Oftentimes it just says what it is that you need to understand about the module, and then you're done. Now, if I have watched this, I need to come and click this, that I have watched it. There's a highlight button there. So I click this, I've watched this. Supposing I also watch this, I will click on it. If I watch this, I click on it, and this, I click on it, and I go on like that. By the time I've seen the entirety of, by the time I've watched the entirety of all that needs to be watched, and I've done resource, the last resource is always a reflection exercise and a written assignment, different from the physical exam that will be done at the end of 4 modules. So resource 8, by the time I'm done with resource 8, it now says new section unlocked. You've completed all lectures in this session. Your next set of lesson is now available. So do you want to continue or maybe later? But because I want to continue, I select continue learning. So now you see that week 2 has been opened. So I have all the resources in week 2 available to me now, and then I can sit and do this. So this takes care of the online platform, is flawless, is effortless. Once you've successfully signed in, it's on your own timeline, it's on your own terms. So I don't know if anybody has been able to do what I did.
Yes, ma, I did mine and it went through.
Okay, thank you very much. The person that has the gadget Infinix X, if you can name your gadget, it will be so deeply appreciated, so that I'm not calling you by the name of a gadget, I'm calling you by your name. Can we get a feedback from you, please? Were you able to do what we did, or do you understand and will be able to do it in your own time?
Yes, I understood what you said, ma. I will be able
Okay.
to do it on time.
Okay, thank you
Yeah.
very much. Thank you very much.
Thank you.
Yes. So the last thing I would want to say is that this course will be updated. Whatever it is that you find there, you may find that on Monday, I have updated module 1. So please, like I said, it's quite dynamic, it's fluid. So I may put some more materials. As I find materials, I may just pack materials there. I may pack links and a number of other things. So those who have watched it, once you see that it's highlighted and it's different from what it is you've watched before, you want to go back and watch it. So that you'll be able to keep track. What I will do is every new resource I had differently from what is there now, I will put it after the worksheet. You know, worksheet is the last resource currently. So by the time you see something after the worksheet, you know, oh, this is newly added, that was not there before. So you want to go and also engage with it so that you'll be able to maximize your learning. All right, I think that covers all. There are 2 other people that should be here, but maybe they have issues with joining Zoom. But this will be hosted on the course platform by tonight, so that we can still go back and watch it for those that did not join us early enough. And then those that missed it will also be able to go back and watch it. Any question so that we can call it a day, and then we know that I would be dropping the case scenario on Tuesday, and on Thursday, then we would be meeting on Sunday by 3 p.m. I will drop the schedule of that meeting online as soon as we're done here. Any final question, thoughts, clarification? Do I have permission to call it a day?
Ma, hello, ma.
Yes, please.
Yes, ma. Please, ma, are we meeting tomorrow or not, ma?
Not tomorrow, Sunday,
Okay, ma.
next week, Sunday. This is like an introduction. The meeting is at the end of the week. You know, when you've watched all the videos, you've attended to the written assignment, we can then meet so that if we have questions, we attend to the questions, then we do the hands-on practicum. And yes, thank you very much. Please, may I know your name, please?
I'm Adeyeye Felix, ma.
Okay. Where are you joining us from, please?
From Ado
Ado.
Ekiti, ma.
Okay, would you
Yes,
be
ma.
able to come down for the hands-on practicum?
Yes, ma.
Beautiful, beautiful. Thank you very much. I will drop the schedule right when we are done.
Okay.
All right. So, Nurse Kelvin, can we call it a day? Do you have any thought?
No, ma, no, ma.
All right. Thank you very much. Enjoy the rest of your evening.
Thank you, ma.
All right. Bye-bye.